Our next presentation, titled Private Sector Partnering with Public Health, a case study from India, will open with a 5-minute video from Dr. Naresh Trehan, who could not be here today to give his presentation. He is a cardiovascular surgeon by training. He is the chairman and managing director and chief cardiac surgeon of Medanta GE, with 1,500-bedded multi-super specialty institute which offer cutting-edge technology and state-of-art treatment facilities at an affordable cost. Responding to the government of India's call to action on TB, he has spearheaded a project in the state of Haryana to increase diagnosis of TB using mobile vans, with plans to expand to other areas. Following his words, Dr. Bornali Dutta, the Director of Respiratory Medicine of Medanta and lead for TB Haryana, will present his project, which she herself actually designed and has run for the last 5 years.
Good morning. I am Dr. Naresh Trehan. I am the chairman of Medanta GE in Gurugram, which is NCR Delhi actually. Sorry, I am not able to make it to this meeting. I was very keen to do so, but because of the conflict with our opening our second facility in Lucknow, which is a 1,000-bed hospital, which is also coinciding with the same dates, that it was not possible for me to be with you. So I am going to give you some brief outlook of what we have been doing. Fortunately, Dr. Bornali Dutta, who is the real champion, is going to be there with you. I am just an accidental TB warrior and will continue to be so. I received an invitation to the Mumbai Dialogue, and when I inquired from the US ambassador what this Mumbai Dialogue was about, he told me that it's about TB Free India. So the flashback came that Dr. Bornali had already done something which I didn't know, so I requested her to brief me on what her study was and what was the result. So she said that they had done a controlled trial in conjunction with the local Haryana DOT officers. They figured out that 50% of the patients who were suspected to have TB, they would go undetected because their sputum would not show mycobacterium. And you needed, and as an additional diagnostics was a digital X-ray, and analog was not clear enough to diagnose. So I said, fine. That means that if we assist the government in its effort for TB control and treatment, which we describe as the DOT program, and just this little intervention that we provided, the digital X-ray first, and then came the CBNAAT also, that if we created specialized vans which could go and assist by rotation every area where there were suspected patients of TB but could not be detected properly, we could help to detect them. That's the intervention Dr. Bornali Dutta and team took. Now this we financed from as our CSR from Medanta GE, and also from donors from around us who were well-meaning and wanted to participate in this TB control program. So when I went to Mumbai, I had back of the envelope said, with the current incidence of TB in India, Haryana probably has somewhere between 25 to 50,000 patients. And it would be possible for us to cover all the 23 districts of Haryana over a period of time. And I must say, you'll get the details from Dr. Bornali, who's the champion. I am the person standing behind her and giving her whatever support, because I am a believer that she will share the details with you. We have covered, I think, 18 or so, and we are rapidly moving to the next few. Now, needless to say that this has been a very gratifying journey to see that the intervention that we are doing has had so much impact that we have been able to actually sift out people or patients who otherwise would have got undetected and infected another 10, 15 people in their lifetime, we think that this intervention is essential and hopefully will spread throughout India. And not only have we then almost covered Haryana, but we have become emboldened to take this program to other states. So right now we've had a conversation and a sort of a early agreement with the government of Jharkhand, with Madhya Pradesh, with UP, and there is some demand from Meghalaya. And we are moving along Meghalaya very rapidly because the Chief Minister is very proactive. So we are going to start these programs in all these 5 states in addition to Haryana in this coming year. So that's what I wanted to share with you, and Dr. Bornali will do the rest. Sorry again that I couldn't make it. Please have a great conference, and I'll get the briefing from Dr. Bornali when she gets back. And we want to now go over one of the things that I forgot to add was the fact that we want to do an outcome study while we are doing all this effort, and we are adopting a block which is Pataudi, which is near us, and Dr. Dutta will also give you the details of that in her deliberation. Thank you very much, and hope to be able to attend the next meeting. Thank you.
Thanks, Dr. Trehan. I feel that he is with us today. Yeah. Next, I would like to welcome Dr. Dutta to present it.
Good morning, and it's an honor to be here on behalf of Dr. Trehan and Medanta, the hospital I work in, and Dr. Trehan's already given an overview. And I'll just take you through some nitty-gritty of the entire sort of thing, how we started. So the focus in this, Dr. Choi gave a very comprehensive national kind of data, and ours is, the focus is going to narrow down just to this project mainly, but the fact that it has scope, significant scope and scale. No conflict of interest to report. Private sector in India is this, array of different players, right from the unqualified practitioner down to pharmacies, nursing homes, and then high-end corporate hospitals. And the importance of this is that 2/3 of our patients will first seek healthcare advice from a private sector, most often the individual practitioner. So in any case, this is the range of private practice we have. And while RNTCP, which is our national TB program, has an overarching influence by way of the flow of how things happen in the TB field, in the entire private sector, the corporate sector, both corporate hospitals, healthcare, related corporates, and corporates via their CSR, that is the corporate social responsibility budgets, can actually bolster the RNTCP very effectively. And that, I think, needs to be tapped into effectively. And that is sort of, and that is the purpose of what we have done. Mission TB Free Haryana, as has been told, is a public-private partnership. And this is the evolution of what was started in November 2015 when we launched it. And we aligned ourselves with our RNTCP, worked closely with them, and evolved with the program. When we first started, it was passive case finding. Then we went on to enhanced case finding. And now the focus very much is on active case finding, and that's what we're going to start with our block. So when we did our pilot in 2014, this was the algorithm, the diagnostic algorithm for pulmonary tuberculosis in our national program. And it was, of course, the smear was the cornerstone of diagnosis. And only when the patient had repeated negatives was chest X-ray recommended. It was well at the bottom of the algorithm. X-ray facilities have been not available in the districts, in the peripheries, and that's where our mobile van with the digital X-ray fitted in quite well to complement the existing system. So passive case finding, and this was what our first van looked like. This is the interior with a digital X-ray. We could see it on the screen, print it out, and have a fair idea of where things stood, especially for the smear negatives. And this picture has been shown. This is us working closely with the district TB officer. When we launched how we envisaged Mission TB Free Haryana was to have, this is the map of Haryana, it had 21 districts when we started, now there's 23. And we divided them into 5 zones, just in terms of proximity. And we thought of having 5 vans which would cover each of these zones in a cyclical manner. And that would go on for a 4 to 5 year period. And when we started, we had a hub and spoke model. So Medanta Hospital is based in Gurgaon, and there were 4 adjacent districts that we covered. This was all timetabled. The timetable was made by the district TB officer who had the actual know of the area. And while this was a good model, we realized that turnout for the camps was really not good enough, and it had to be better considering how much resources was being channelized into that. Around that same time in 2016, our diagnostic algorithm changed. And of course, WHO's focus changed as well, and they recommended chest X-ray now as a screening tool to be used. In keeping, our program now pushed the X-ray up right to the top. So if a presumptive patient came to you, not only was smear done, but also chest X-ray were available. So no extra facilities were provided, but we could go ahead and do it. We didn't have to wait for repeated negative smears before we could do it. And then was the introduction of the CBNAAT or the GeneXpert, which I think was a tremendous game changer at every level of TB diagnosis. This led us on to enhanced case finding, which essentially meant that we just tried to mobilize the community, spread awareness that the van would be coming and anyone who was chest symptomatic presented. So pamphlets, banners, and using the help of our grassroots workers, the ASHAs, who are essentially the link between community in the rural communities and healthcare services. So we would dedicate anything between 3 to 6 weeks to a district, and we would go, again, PHC-wise, CHC-wise, covering the entire district. And once that was covered, we'd move on to the next district and then return. And again, the key thing was to create a lot of awareness ahead of the camps so that people were aware that this van would be coming and then they would present to us. So this was in Mewat, which is a district in Haryana with exceptionally high TB load, and we had a very good turnout that time. So we continued along these lines for the next 3 years. And the result of the 3 years, the pilot was the first year, 2014, and that's a single district. Then we went on to 5, then 13 and 16, and this year we've covered 17 districts. And just the top zone, the northern districts are yet left, but we hope to do that in the next year. And the results as well, we've sort of increased the numbers screened. Roughly 30% of the population that we have screened of chest symptomatic come out to have abnormal X-rays, and around 10% of those screened then go on to the DOTS program, and that has been the overall sort of experience we've had. What changed things significantly was the addition of the GeneXpert Edge. Now the X-ray, the difficulty with X-ray, as we all know, is that it's highly sensitive, very poor specificity, and medical officers in the primary healthcare centers often don't know how to interpret it, and that is a problem. So the program often discourages the use of chest X-ray as the final diagnostic tool, and there's good evidence to support that. So while we were doing X-rays, there would be times when we couldn't really push through the diagnosis. So that was changed by the Edge. So the Edge is the GeneXpert. It's the very same thing, except that it's a single module, and it was developed for its portability and sturdiness. So it comes in a case, and then we'd carry it in the van, and then when we reached there, we could open it out, and then the ones where we felt chest X-ray was strongly suggestive, we'd go ahead and do it at point of care. And again, that's vital because often we find in these districts, the patient will come to you once, and that is your one chance to sort out the diagnosis because you don't know if the patient will return because distances are immense, and that's what we face. So then that's what we started doing. Chest X-ray, strongly suggestive, would then undergo a CBNAAT at the same time, then and there. And these are just examples of X-rays which are strikingly abnormal, and we've done a GeneXpert test and detected low with RIF resistance, and this is again another one detected high. So in a 6-month period that we used the Edge, which was this particular single module CBNAAT, we screened with chest X-ray 1673 patients. The total CBNAAT done was 176, and total detected was 82, so very high. So when there is a strong clinical radiological suspicion, I think CBNAAT, it corroborates very well with a positive CBNAAT result. So 47% positivity rate, and we diagnosed 6 MDRs. So it may well be that they all would have gone diagnosed eventually, but we don't know when that eventually is. And I think ultimately we just reduce the delays in diagnosis, which is one of the key reasons why the TB sort of keeps perpetuating. Now coming to active case finding that Dr. Trehan briefly touched about. Now along with the program, now the emphasis is on eradication, and then it's active case finding with door-to-door. Then you can't even leave out a single household. So Pataudi is a block. Now Gurgaon is a district, and within it we have our city Gurgaon where our hospital is based, and Pataudi is a block close by, 40 minutes drive from us. And a block is much more contained. So the census back in 2011 was 3.5 lakhs, which is 350,000, and but realistically it's probably closer to 600,000 to 700,000 people. So it's screening all of them and then identifying them for sort of X-ray and CBNAAT and smear. Now, the only difference at this is that we really want to engage community in this. So we have the government driving it, we have NGOs, we have the private sector now, buying into this, but the community, till they take ownership, I think we will not be able to eradicate it. And in our case, community is vast because, our population is so enormous. So we have done multi-level meetings, and this particular one is very good because we have the ASHA workers, we have sarpanchas who are the local leaders. They are the sort of the smallest unit of government in the village. They are the leads of that. And it is essentially to just draw them all into this program. The method is simple. It's door-to-door questionnaire with the volunteers. We will engage volunteers with ASHAs, and then the ones who are chest symptomatic, ask them to present to the camp. The mobile van will be taken to a far more remote location so that they have access to it. We have yet to start. We were going to start in October. There was elections, and so it's been deferred to mid of November. And we hope to sort of achieve the first round in 6 to 7 months, and then pause to see the effect, and then repeat. And this, will go on till we till elimination happens. And we hope to essentially develop a cost-effective model that can then be scaled up. Engagement of other corporates, and this I think is a key role played by Dr. Trehan because vans have been given to us by different corporates, Siemens, Oriental Bank of Commerce, RJ Corp, Wrights, Philips, and then Medanta has fabricated them and run them. How we have managed to engage them, again, I think effective leadership by Dr. Trehan, having credibility as an organization, working closely with government, and then demonstrating a model that works and that has been successful. We are one of the first partners that the union engaged in the call to action when Dr. Trehan went for the Mumbai dialogue, and the union have been strong partners and catalysts in everything that we have done. We also pledged as one of the corporates in the USAID corporate pledge event held recently in Delhi. Now the way forward as we tackle our block is to increase our remit. So far we've just been diagnostic led, and we do the diagnosis and we step back because the government has everything else laid out. But we feel now more engagement is needed, and essentially we have to complete this loop, the entire continuum of care. So starting with awareness through diagnosis, treatment, adherence and completion, which are again key things, and then going on to behavior change campaign. And we hope to achieve this in our block because we now have a consortium of partners, and that GE who are technological partners, we have the union as knowledge partners, KPMG as monitoring, etc. And this may be the way forward, small consortia who have a skill mix. And that I think will lead on to being able to sustain this as well. So our consortia has clinical, technological, social, financial facets to it, which will then lead on to innovations. Now, innovations is, of course, the buzzword, but I feel strongly that we also need to effectively use what we already have. We have X-ray, we have smear, we have CBNAAT. I mean, this is pretty good, a good armamentarium for diagnostic, and I think we just have to use it effectively. And then funds, of course, CSR funds, it's mandatory for all corporates to contribute, and I think we do need to tap into that to ensure sustainability. Scaling to other states was also mentioned, and this is the plan around March to go on to 4 more states other than Haryana. And I've just highlighted Meghalaya because that's a state in the northeast part of India, and it's an extremely hilly terrain, so very different to the plains that we live in. and the challenges will therefore be different. So we actually paid a visit in August to Shillong with our RNTCP team to thrash out a few things. And just to point out, the challenges faced. So Meghalaya, it's a small state, as is Haryana. Meghalaya is half the area of Haryana, but has 1/10 the population. So the population is very scattered, sparsely distributed. On the same token, the population of a village in Pataudi in Haryana or Gurgaon would have 2,400 people, inhabitants, and a village in one of the districts of Shillong has 475. So, the van will have to just traverse far more to reach everyone. So I think the challenges are different in different areas. We have done research and publications. We published the pilot with the union and then a cost effectiveness study. And just recently, 5 years of this PPP was in the Indian Journal of Tuberculosis. So this is work in progress. So overall, I think we have developed effective partnership with a lot of support of people around us, the government, most of all, for allowing us to work with them and work with them closely. The private sector is us and others who have joined up with us, and the NGOs. The union have been, as I've said, very strong force behind all of this. We have a committed team on the ground who work well beyond their call of duty, because they do long hours, arduous hours out of the hospital in sort of 45 degrees temperature heat and things like that. But they've sort of continued to do it, so that's great. And then finally, effective leadership. And Dr. Trehan calls himself an accidental warrior in this battle against TB, but clearly none of this would have happened had he not backed it and supported it with his with his position where he is. Thank you very much for your time.